starts from developing from this particular sac, we call them as yolk sac, which gets inside this developing embryo, forms a tube which can be divided of three parts: foregut, midgut and hindgut. Hindgut we are discussing in the previous sessions, which has a communication, we call them as vital or intestinal duct. That particular duct I keep on telling is very important for us. We are going to talk about today why this particular vital intestinal duct is important. And in this particular middle portions of this particular gut, we have learned this particular middle gut herniates out. We call them as physiological herniation of midgut tube, or known as primitive primary intestinal loop, or PIL. That particular loop goes out naturally and comes back between developing phase of this developing embryo, between 6 weeks of life and 8 weeks of life. We learn about this particular phenomenon, which is known as physiological herniation of midgut loop. We call them as physiological because it happens to every individual, it's temporary, and it has some reason for going out and coming back. And this is sometimes is given as exam short notes. But coming from this particular phenomenon, which is known then as physiological herniation of midgut, during this going out and coming back, it makes some sort of turning. We call them as rotation. Now, this particular turning, we have to keep that in mind. While going on, it is 90-degree anti-clockwise. Coming back is 180-degree anti-clockwise. It makes a rotation, and together joining them, we get a 270-degree rotation anti-clockwise. This particular rotation is important to place this gut in place like the way it is. Like, because of this particular rotation, the gut which is getting back gets some place in the abdomen. So, we have a rule to follow whenever this particular gut returns to the abdomen. Whichever returns at the beginning gets to the left side of the abdomen quadrant and settles there, and whoever gets back at the end settles down to the right side of this. And if you have any mismatch in that, we have diseases which related to it. Now, this particular physiological herniation goes in axis of this SMA, superior mesenteric artery. This particular physiological rotation runs along which longitudinal axis or which axis artery. This is sometimes given as a MCQ, like that's word SMA or superior mesenteric artery, which makes an axis for the rotation and axis for this particular reverse rotation. That comes as an exam like MCQs. Other than the rotation physiological is a short one. Now, coming from this, the consequence of this particular going and coming back, we call them as retractions of the herniation loop or herniations. We have some sort of fate of this. Now, what this particular consequence of this particular rotation and reverse rotation is that we have this mesentery which is placed to it. We call them as dorsal and ventral mesentery. The dorsal mesentery, which is extensively present in this part of the gut. Some part of this particular gut which is present to this particular, especially in the large part of the gut, during this particular rotation and this particular movement, it loses this mesentery. As a result of this, we have seen that this particular part of the large gut, we call them as ascending colon, and as well as this descending colon, loses the mesentery and gets fixed to the posterior abdominal wall. And so is the pancreas, which also rotates because of this particular rotation of this particular stomach and this particular duodenum. So, which also gets plastered on the posterior side and becomes retroperitoneal. So, fate of this particular rotation of this physiological herniation is that some of this particular large gut loop becomes retroperitoneal. This is also an exam MCQ. They ask about this particular consequence of this particular physiological herniation, which is because of this particular herniation, this mesentery is lost within this particular gut, and they are plastered on this particular wall of the posterior abdominal wall and remains become their retroperitoneal, namely the ascending colon, descending colon, and this organ which is placed on the back side, we call them as pancreas. Rest of this particular gut, like transverse colon, sigmoid colon, and the cecum and appendix remains there as it is. So, this is a fate of this particular loss of mesentery which happens there. Next thing is that as this particular thing is growing, this particular primary intestinal loop is making this particular small gut loop, large gut loop. There is a development of the diverticulum on this particular midpoint of this particular cranial caudal, cranial axis of this or cranial limb of this particular PIL. So this primary intestinal loop have got two arms. One is above, one is below. We call them as cephalic limb and caudal limb. Now the caudal limb, this beginning part, like proximal part, which is close to the vitelline duct or close to the point where this axis artery is going, here we develop some sort of diverticulum or outpouching. That outpouching goes to form a blind pouch, and from there another outpouch grows, which eventually forms the cecum and appendix. So from this particular like primary intestinal loop, we have these particular things develop, like all the coils of jejunum, ileum and lower part of the duodenum, and then we have the cecum, appendix, colon, and to this particular 2/3 of this particular transverse colon, which has developed from this particular primary intestinal loop or this particular gut loop. And this particular gut loop goes out and come back. We call them as physiological herniation. Fate of this particular physiological herniation is losing some sort of mesentery from it. So this is what we have to take from this particular point. Other is the clinical problems, which are your exam questions. We usually give this particular exam question as a short note. The fate of this particular clinical problems arising of these particular problems of the rotations or rotations error. So one of these particular problem which commonly comes here is known as omphalocele. Now this is a kind of distinct kind of abdominal problem that we encounter here. This developmental error that we are seeing right now is an important entity that we see given as a clinical question. Now this picture is given as a descriptive note in examination, like a kid born with a transparent membrane covered in the umbilical region, which is having a visibility of the coils of small intestine or large intestine or gut loop, or parts of the organs are visible. And they ask you about make a diagnosis of this particular clinical problem, which may have a clinical problem related to genetic problem as well, like trisomy of 13 chromosome or trisomy of some chromosomes is associated with it. And they ask you to diagnose this particular problem, and they ask about what is the root cause for this particular problem. Now this particular problem, what you see here is the gut which is present in here is covered within this particular transparent membrane, and anterior-abdominal wall cavity is basically exposed in this region. So this particular problem we call them as omphalocele. Now what you see here, this particular intestinal loop that is coming here is primary intestinal loop, that we call them as PIL. Now whatever the things has developed from PIL or primary intestinal loop, that means coils of the jejunum, coils of this duodenum and coils of this particular ileum, transverse colon, cecum, etc., they are wrapped in this particular point. Now this particular PIL goes outside on the physiological herniation and then gets back normal, and then we develop this particular anterior-abdominal wall and everything is sealed and covered, we are born. Now what happens, by any chance this particular herniation that goes outside and never comes back, we call them as persistence of physiological herniation. That means the gut loop or PIL goes to this umbilical cord and remains there, forgets to come back. That particular phenomenon, if it happens, that yields this kind of clinical problem. We call them as omphalocele. So it is also known as persistence of physiological hernia, where the viscera fail to return, that means gut loop fails to return and remains there and covered with this particular transparent membrane like structure. So this particular problem is nothing but, you have to explain this particular entity as a persistent of physiological herniation which happens between 6 weeks of life and 10 weeks of life. The return of this gut loop or primary intestinal loop never happens and it remains there. It may be having association with this particular like a chromosomal error like trisomy 13 or Edwards syndrome like 18th chromosome error, which may be there, where you see this gut loop along with this particular peritoneum remains within a sac like this and becomes visible. Very hard to treat, make this particular individual to survive. We have to do extensive cosmetic surgery and extensive like backup surgery to cover this particular thing, and despite that, because of this particular genetic error or maybe some other underlying error may be associated with this, they have a poor survival rate into this particular individual. This is one form of persistence of physiological herniation. We call them as omphalocele. Even a grave variety can happen. We call them as gastroschisis, where we do not have this covering that we used to have in omphalocele. The gut which is to covered by this particular mesentery or peritoneum fold, is absent here. That means this particular gut tube or primary intestinal loop is exposed to the alkaline amniotic fluid and remains burned or charred between this particular fluid over there. So this particular gut which has been exposed, organ is exposed to the amniotic fluid and remains partly destroyed in here. And associated with this problem, we have the persistence of the physiological herniation is there, and as well as the anterior abdominal wall is not formed in this particular region, especially the under umbilicus or below umbilicus. So this kind of problem we call them as gastrocschisis. This individual never makes a life like hard to survive here. So anterior abdominal wall close to this particular umbilical cord, umbilicus, right side, left side, or infraumbilical region deficiently formed, and this particular gastrocschisis is having this particular gut loop remain there because of the persistent herniation. This is less frequently given or do not given in examination so far I have seen, but omphalocele is a kind of problem with the clinical questions that is being given with a narrative, and they ask about this particular, why this particular thing happens. They want to know about this particular phenomenon. We call them as physiological herniation, and this physiological herniation like a thing which you call them as persistent of physiological herniation. Now from there we are going to talk about other problem which is related to this particular physiological herniation, is that the rotation error. So we learned this particular physiological herniation happens with some degree of rotation which is happening 90 degree and anti-clockwise, which is happening there, and gut rotation error may happen. So instead of what you see that 90 degree anti-clockwise that is happening when this herniation is happening, and 180 degree herniation rotation which is happening in the reverse time, again anti-clockwise, that is not happening properly. So in some of the cases we have seen that there is only 90 degree rotation, and that too this particular 90 degree rotation which is taking place, the reverse rotation never happens. That means 180 degree rotation not happening. That leads to a formation of these things. So whenever the organ is getting back, the faulty organ is getting back. So this large intestine cecum gets back first. Initially what we have learned, the jejunum is returning first. In this place, if you do not have this particular 180 degree rotation in the reverse phase, we have this particular problem. We have this gut, large gut, cecum, ascending colon, transverse colon returns first, and the rule is followed there. Whoever is returns first goes to the left side. So this particular colon settles to the left side of the individual. Cecum goes to the left side, appendix goes to the left side and settles there. The jejunum and the ileum goes to the right side. So this kind of problem, if this individual is born with, we call them as left-sided colon. Now, what's the problem with this? If you have the malpositions in this gut region, we have a problem. What problem that can happen? We have a rotation which is taking place in a faulty manner. That's not the problem. Problem is we have the peristaltic movement goes with this passage of the food. Now, during the peristalsis, we have some movement taking place between these particular coils of the intestine. So, if you have a faultily paced organs, especially the gut there, we have the pace of the peristalsis may be altered, and that can lead to a formation of intestinal obstructions, volvulus, or any kind of error which is leading to twitching or twisting of this particular gut loop. That can lead to strangulation. That means that is like everything is jumbled up and stopped there. So we call this kind of clinical problem as intestinal obstruction, volvulus, etc., which you're going to learn in higher classes like surgery, etc., etc. So that can happen with this consequence of that. But we do not have to learn all the details of it. Only thing you have to learn about, instead of 170 degree rotation, if you have only 90 degree rotation, that can lead to left-sided colon. Left-sided colon, why I am emphasizing? Because that's also an MCQ that is being given in examinations. So left-sided colon found in rotation problem 90 degree, 180 degree, or whatever the choices they are going to be given, and you have to pick up the right choice. Why this particular left-sided colon happens as a developmental error. This is what we have to know about, like in the gut error related to the midgut loop. Other than this, we have to talk about this particular entity. We call them as vitalointestinal duct. Now we talked about vitalointestinal duct. What do you mean by the vitalointestinal duct? That primary loop which is communicating this particular midgut loop, which you have learned there, where this particular midgut is communicated from this particular yolk sac, that particular channel we call them as vitalointestinal duct. So if you go back to this particular picture, we see that this channel we call them as vitalointestinal duct, which is communicating this particular midgut with this particular primitive yolk sac. So this channel, not the whole thing, this channel we call them as duct. This channel we call them as vitalointestinal duct that should normally been absorbed, completely destroyed, no trace should be found. But if this channel remains to be present in an individual, that can create a kind of pouch. We call them as diverticulum, and that particular diverticulum we call them as Meckel's diverticulum. That particular diverticulum, if it is present, that can create problem in terms of if it is inflamed. Now about Meckel's diverticulum, again it is an exam short note. They ask about, write a short note about Meckel's diverticulum. That means you have to write about Meckel's diverticulum, the developmental reason for it. It is nothing but the persistence of vitalointestinal duct or remnant of the vitalointestinal duct remains there, patent there, and creates a kind of diverticulum that is known as Meckel's diverticulum, also known as ileal diverticulum, because it is present on the ileal loop. 2% of the individual is having this particular, 2% of the population may have this particular diverticulum present, and the locations of this particular diverticulum is 2 feet from the ileocecal valve. We learned about ileocecal valve in this particular large gut in the cecum. So it is 2 feet from that particular point towards this ileum side, this particular diverticulum is there. Now it having a length or size of 2 inches. So it goes by the rule of the 2% people, 2 feet from the ileocecal valve and 2 inches in length. So this is about this remnant, we call them as vitalointestinal duct persistence. Now problem with this particular duct remains like outpouch like this. This is like this. In a clinical case you are seeing. This is an ileum loop that you are seeing here, and from here you can see this particular long diverticulum present. Now this diverticulum, if it is present, posing no problem whatsoever. If it is infected, so if this ileal diverticulum is infected or Meckel's diverticulum is infected, we call them as Meckel's diverticulitis. Now this Meckel's diverticulitis is a problem. Why it is a problem? That because that mimics the clinical problem or clinical scenario of acute appendicitis. Now what does it mean? So this ileal diverticulum, if it is inflamed, can create a similar case presentation like acute appendicitis. Now what do you mean by this clinical presentation of acute appendicitis? Now we have learned this acute appendicitis is a clinical condition where the appendix is inflamed. Now inflamed appendix can create a problem like pain in the abdomen. We know the quadrant where this pain is coming on this region, we call them as umbilical region, because T10 dermatom supplies at that particular point. So the patient comes with the pain and the abdomen which is restricted around this umbilicus following the T10 dermatom. Now if you do a clinical examination on the patient who has this acute appendicitis, we see that McBurney's point is tender. Now what do you mean by McBurney's point? That's a point which is lying joining this ASIS to the umbilicus at the junctions of the medial 2/3 and the lateral 1/3. If you fresh on that particular point we call them as McBurney's point. In a normal healthy person, it should not have any pain. In case of the acute appendicitis, we have pain on that McBurney's point. We call them as McBurney's point tenderness positive. If you press it or release it, depending on the state of this acute appendicitis, we have the pain. So this is a clinical case. Now you get a patient who is coming with the similar clinical problem. So pain at the T10 dermatom and pressing on the McBurney's point, you make a call that is McBurney's point tender. You have acute appendicitis and I am ready to do operate on it. And you open the abdomen. And opening the abdomen, you find the cecum and appendix, which is most common positions of the appendix is retrocecal. You find the retrocecal appendix is perfectly healthy, normal. What do you do now? Cut the healthy appendix and come out and say, oh, you had a diseased appendix, but now it is recovered. Now suture it back, stitch it back and let the patient go. So now the appendix is no more paining. But again, a week after, a patient is coming back. A month after, is patient coming back with the same clinical problem. Same dermatome pain, same McBurney's point tendon. Now what you are going to do? You already have thrown out this appendix, but you have no knowledge about ileal diverticulum. So then what you are going to convince your patient with? So you have something other problem. Again, I have to open your abdomen and find nothing. So for that reason, this is what is a dictum is, if you diagnose a case with this acute appendicitis, even you find an appendix which is diseased during surgery, which you have made a right call, acute appendicitis, but make sure you check this particular point, 2 feet from the cecum towards the ileal side, check whether they existed with this ileal diverticulum or not. Because 2% people will have this ileal diverticulum. So 2% population, like if this class is taken like a 100 population, 2 of you may have this particular ileal diverticulum. So that's why whenever you have a case of acute appendicitis, you are doing the surgery right, correct, and then you cross check other thing as well. You check this ileal diverticulum if it is existing or not. That can create the same problem afterwards if it is not taken care. Alright. So this is what we have to take over there, this particular problem. Other problem with this acute Meckel's diverticulum is that this Meckel's diverticulum normally contains the mucosa, which is ileal mucosa. That means that ileal glands, whatever the things are there, lymph nodes, everything is present within these particular layers, within this particular Meckel's diverticulum. In addition to that, this Meckel's diverticulum may hold some foreign mucosa. What kind of foreign mucosa? It can have a mucosa coming from the gut, which is coming from this particular GI tube, which is coming from the stomach, which may be coming from an extra pancreatic tissue, may be there, which may be secreting insulin. So that reason, for that reason, this Meckel's diverticulum is other problem. You see that if it is persistent, it may have ectopic tissues, which you are going to learn in surgery. The ectopic positions of like insulin secreting organ, so other than pancreas, which may be the Meckel's diverticulum mucosa, which may be your MCQs like this. So gastric mucosa may be present in here, pancreatic tissue may be there, secreting the gastric juice, secreting the pancreatic juice. If the gastric juice is coming, they may be secreting this particular gastrin hormones. If the gastrin is secreted there, there may be hypersecretion of the acid there. So there is a cause of hyperacidity in some individual who have gastric mucosa in the ileal diverticulum. That's a complex phenomenon that you're going to learn in clinics about this particular presentation. I don't know whether this particular clinical setup will give you this particular clinical cases or these particular problems in your life you will be seeing or not. I'm not sure, but these are clinical problems are presented in our life with these particular problems with this hypersecreting gastrin hormones or extra source of insulin hormone other than this particular pancreas. So these are the few clinical problems related to this particular developmental error in the midgut loop that we have to keep in mind. Omphalocele, ileal diverticulum and left-sided colon. I would recommend to prepare these for your short notes and MCQs. Now this is about this midgut loop and we are moving to this particular other end or the lower part of this particular thing. We call them as hindgut loop. The hindgut loop that we are going to focus here is this particular circled region. That means hindgut loop. Beyond this PIL, anything beyond, we are going to talk about, we call them as hindgut loop. That means same tube which is going down and making a blind pouch. That's what we are going to talk. Now what develops from the hindgut tube? That means which is yielding the distal third of the transverse colon, descending colon, sigmoid colon, rectum and upper part of anal canal and a portions of urinary system. What portions of the urinary system? The inner lining of urinary bladder and urethra lining. So this lining of the urethra and the bladder is also coming from this particular hindgut derivative. Now this part we miss during examination. So this is your MCQ. That's why they focus in this particular foregut hindgut derivative with the MCQ The derivatives from hindgut tube are all except or all. Pick up the best choices. So, we forget about this particular lining or internal lining of the urinary bladder and the urethra, which also comes from the hindgut or primary intestinal of this particular hindgut loop. So, this is what we are going to talk. We are not going to talk elaborate versions of this particular hindgut loop. Only thing we are going to emphasize here, this particular hindgut loop which is ending in this particular region. So, lowest most portion of this hindgut loop is our point of concern. Very short, very precise, 5 minutes that we are going to spend out here. So, this lowest most portion of this particular hindgut loop or caudal most part of this hindgut loop which is ending here, we give this blind pouch a name. We call them as cloaca or cloacae. So, this blind pouch that we are seeing here is point of concern about development of the hindgut loop. So far in the foregut loop, midgut loop, we will run through detail of it. In case of the hindgut, we just focus in the distal most part which is running in this particular region, we call them as cloaca. So, this blind pouch we call them as cloaca. Now, this blind pouch is lined by this tissue which is lying over here, make a bend here. We call them as proctodeum. So, this particular proctodeum is on the skin side, and between this proctodeum, skin side, and this particular cloaca, we have a membrane existing. We call them as cloacal membrane. So, these three words are that we have to emphasize or have to focus. So, this blind pouch, we call them as cloaca. The blind pouch ends in the skin region, makes a dent. That depression, we call them as proctodeum. Likewise, the foregut tube, the mouth region, we call them as stomodium. Here, we call them as proctodeum. And between this depression, which is known as stomodium, and this blind pouch, which is known as cloaca, exists a thin membrane, we call them as cloacal membrane. So, this entity we have to know about. So, this particular cloaca, you see that having a outgrowth or outpouch, which is this one, which is going to this umbilical cord. So, this diverticulum of cloaca, we call them as allantois. So, we will deal with allantois later on in the urinary system development. So, we know this particular word allantois, which is a diverticulum coming here, and we learn about the development of allantois or developmental sequel allantois in other classes. So, we just focus in this cloaca, we just focus in the proctodeum and this cloacal membrane. Now, we have a mesodermal tissue running into this particular body shaft. So, this particular body lower end, tail end, caudal end, we have this mesenchymal tissue. So, which is running between the allantois and this particular cloaca. Now, slowly, what you see that this particular separating mesenchymal tissue becomes condensed and makes a septum between allantois and this cloaca. We call this mesenchymal tissue between them, we call them as urorectal septum. Now, this urorectal septum transforms into times A, B and C. These are the sequel of the urorectal septum. This is a picture A, early phase, then is intermediate phase and this large phase. What happens? This urorectal septum, which is a mesenchymal tissue, grows and splits this particular cloaca gradually from picture A to B, splits into two halves, ventral half and dorsal half. This is ventral side of the body, this is dorsal side of the body. So, it splits this cloaca into two halves, anterior part and the posterior part. Now, we focus in the posterior part, we leave the rest anterior part for other future classes. Now, we follow this posterior part which is present in here. So, this mesenchymal tissue which is known as urorectal septum splits this cloaca, and along with this particular cloaca, this cloacal membrane and proctodeum into two parts, anterior part and posterior part. Posterior part of it, which you are seeing here, present in here, this particular cloacal membrane split into two parts. Anterior one we call them as urorectal or urogenital septum. The posterior one we call them as anal septum or anal membrane. So, we change the name in here. So, what forms here is the future anal canal which is coming out here from this cloaca. So, this anal canal, as you have learned, have got two parts. If you have not learned, learn it. we divide this anal canal based on its development into two parts and based on gross anatomy also into two parts. There is a imaginary line existing here, we call them as pectinate line. So that particular pectinate line is important for us to remember. So this anal canal, which has an upper part and has a lower part, split by this particular line. Above this upper part and lower part is sourced from different region. So this pectinate line is basically the line which is representing the anal membrane. And above this particular anal membrane, this upper part of this particular anal canal represents this cloacae. Now this lower part, the lower part is basically develops from this indentation that we call them as proctodium. This proctodium is basically present on the ectoderm or skin side, and this proctodium grows in, gradually makes a pit, and that particular pit gets communicated with this cloaca once this particular anal canal membrane ruptures, and that creates a complete anal canal that we have with the muscles and the mucosa. So this is about the phenomenon of anal canal formation. Now we do not have to know about this narrative because nobody asked about describe this particular anal canal formation. But what information that we have to keep in mind is the formations of the anal canal is from two sources, upper one and lower one. Upper one is coming from cloaca, lower one is coming from the ingrowing proctodium part, we call them as anal pit, which is going in. So this upper part of this anal canal that we are seeing here is developing from the endoderm tube, that means it is endodermal in origin, whereas this particular lower part is ectodermal in origin. And that is why this anal canal is having two different nerve supply, two different blood supply, two different lymphatic drainage, two different innervations based on this region supply. So upper part is supplied by something else, lower part is supplied by something else. That's why this anal canal have got two different sources of different arteries, lymphatics, nerve supply, etc., etc. So they ask you to explain why this anal canal upper part is supplied by the visceral nerve like autonomic nerves, whereas lower part, which is close to the skin, is supplied by the somatic nerve. Why the blood supply is coming from the middle rectal and the superior rectal artery from above, the inferior rectal artery is supplying this lower part. Lymphatic drainage goes to different group of lymphatics. Above is going to the iliac group, lower one is going to the inguinal group, etc., etc. Explain why. So this explanation comes with this embryological knowledge how this anal canal is formed. Unless you explain this, understand this particular development of anal canal, upper part superior to third, lower in third is coming from two different sources. Upper one is coming from cloaca, lower one is coming from proctodium getting in, and this particular communication only gets communicated if this anal membrane breaks in or ruptures. If this anal membrane fails to break in, we have a clinical problem. This clinical problem, we give you a clinical problem related to this particular non-rupture of anal membrane. That particular problem is known as imperforate anus, which is your exam question. So imperforate anus is because of non-rupturing of the anal membrane. Now how do you think this particular imperforate anus is going to come to you? They will have the normal anal pit or normal opening which is present. So this anal opening is there. The lower part of the anal canal is also there, but it is ending in a blind pouch because this membrane is not ruptured, it is there. So this particular anal opening or anus opening ends shortly like 1 to 1.5 centimeter beyond in a blind pouch. So this particular condition, we have the fecal matter reaching up to this particular point, we call them as upper part of the anal canal and not coming out. So this clinical problem presents with the kid who are born with with imperforate anus is not passing stool 3 days, 4 days even after born. So, taking the food but not passing stool. The first stool the kid passes, the newborn passes, we call them, okay, anything, we will talk about this later. So, the stool the kid used to pass by 12 hours. So, the person or the kid newborn takes the food and it should be coming with this particular fecal matter by 12 hours. If you have non-passage of stool passing or non-passage of stool beyond 12 hours, it should arise suspicion. What kind of suspicion? The kid may have this particular problem, which is known as imperforate anus. So, this particular imperforate anus is a kind of clinical case that we see in our clinical life based on this particular non-rupture of anal membrane, and these things need to be done with or repaired with surgery, because this imperforate anus is many a times we see that is maybe associated with the pelvic diaphragm or any kind of pelvic structure error as well. So, this anal pit that you are seeing here is a blind pit, which is ending in the blind thing and you have a membrane. So, you have to bridge this membrane, cut it through, suture it, do a surgery, put a tube inside if it is required, and then this fecal matter can come out. So, this is how this particular imperforate anus, which is happening because of this particular failure to rupture this anal membrane. This is your again MCQ. They will be giving this particular lots of MCQs based on this particular embryological errors. So, this particular imperforate anus is not about not formation of anal canal, not formation of this cloaca or not transformation of cloaca. It is about non-rupture of this anal membrane which failing beyond this 7th week or 8th week of life. And if it is not breaking at that 8th week of life, it is not going to break, it is going to remain there. So, this particular problem commonly we see that as MCQ and as well as short exam questions. So, imperforate anus and the significance or clinical explanation related to this particular parts of the anal canal having two sources of origin and two sources of arterial supply, lymphatic pain and epithelium, difference between them are need to be explained with your embryological knowledge. So, this is what we summarize related to this particular like a hindgut developmental error. This urosectal or urorectal or rectovaginal fistulas we will talk about in genitourinary system develop. I am just developmental classes. I am not just talking it right way. We just restricting this particular discussion to this particular clinical problem related to the formation of cloaca, which is a blind pouch that is separated from this diverticula which it has, we call them as allantois, and this particular septum which is created in between, we call them as urorectal septum, which splits this cloaca into two parts, cloaca on the posterior side and this particular urogenital sinus or urogenital part which is in the front side. And in here we have this particular anal membrane existing between this particular upper part and the lower part of the developing anal canal, and if it fails to break by this end of 8 weeks, it remains as a membrane, and the clinical problem we call them as imperforate anus. Imperforate anus again many a times we see that given as a short note or maybe an exam MCQs. So, this is about the development of the GI system that we are having covered with, and next class onwards we will move to this particular development of urinary system or genitourinary system development. So, this is all for us. Thank you.